All right. Good morning, everyone. Thank you so much for joining us today. Welcome to another session of EMI Live, an initiative by the Cleveland Clinic to disperse education to outside endocrinologists and any other healthcare professionals. We are delighted today to present a very interesting topic. We are talking about COVID and thyroid function today. We're going to start with a very interesting case. Dr. Michelle Lundholm, one of our second year fellows now, is going to be presenting a case today. We have two panelists today, Dr. Sandra Hong, who is the director of the Center for Food Allergies at the Cleveland Clinic, and she's also the regional director for the South region, along with Dr. Leah Hage, who is staff and a thyroid expert here in our institute. Dr. Lundholm, please go ahead.
Thank you, Dr. Makin, for that introduction. Just minimize this. All right, so welcome everybody to EMI Live. I'm excited to take us through a case today called a case of subacute thyroiditis after SARS-CoV-2 vaccination. Our case starts with a 36-year-old female who presents for palpitations. So these are new onset. They're also associated with dyspnea, lightheadedness, and hand tremors. They're also simultaneously associated with anterior neck tenderness and pain radiating to her left ear. She's had these symptoms for the past couple weeks or so. She denies any other local symptoms. She denies any new hypothyroid symptoms. She does endorse some chronic fatigue and difficulty losing weight, but there's not been anything acute or new, no cold intolerance, weight gain, or constipation. She denies any weight loss, heat intolerance, insomnia, or diarrhea, and she denies any fevers, chills, or night sweats. She has not had any recent illness or contrast or high iodine load exposure. However, she does say that the onset of her symptoms was 10 days after getting her COVID vaccine. And her vaccination was otherwise pretty uneventful. It sounds like she had an experience many of us did, which is that she was pretty malaised for about a day afterward. She does not have too much past medical or surgical history. So she has a history of seasonal allergies. She has a history of PCOS, and there's a question about a prior thyroid nodule. It was suggested on a 2008 ultrasound. She hadn't had any imaging since until this visit. And then she does not have any surgical history. From her family and social history, so she does have some hypothyroidism in the family. Both her mother and her paternal grandmother had hypothyroidism. Her aunt had a goiter, and there's no other known history of thyroid disease. She works in HR, does not use any tobacco, and rarely drinks alcohol. On exam, so reportedly her vitals are normal. She is well appearing. She's not in any acute distress. She does not have any proptosis or significant periorbital edema. Her neck is, she has a trachea that's midline. There's no visible thyroid enlargement or asymmetry, but she does have this thyroid tenderness. Her heart rate is regular. She does not have any murmurs. She is not in any respiratory distress, and her abdomen is soft and non-tender. There is no edema, specifically no pretibial myxedema, and her skin is warm and dry without vitiligo, and her mood and affect are appropriate. So here are the initial results we have for this patient. So you can see that her thyroid receptor antibodies are negative. We don't have an ESR or CRP or IL-1, unfortunately, or IL-6, excuse me, unfortunately, but we do have some thyroid labs going back for this patient. So we can see at the time of this visit, we're in the end of March. You can see we have labs going back to October of 2017 as well. So before I move forward, would someone like to tell us how they would interpret these labs and what their next steps would be?
So if you look at this blood work, it's consistent with hypothyroidism. So her TSH is suppressed, her creatine pouring, her beta elevated. Now the interesting thing is if you look back at all her prior blood work, her thyroid levels were not. So surprisingly, she had her antibody test that came back really fast, so that's what's negative. Her symptoms that she's complaining about, she has the neck pain, thyroid pain. She does have a family history of thyroid disease, but thanks to the autoimmune disease in the background, her antibodies are negative. And I would say, yes, she has hyperthyroidism, but we do need to evaluate further to see what's going on.
Exactly. So our first step, or I should say, the team's first step at this point was to repeat the labs to confirm that this thyrotoxic phase was resolving here. Yeah.
What did you think about the September 2020?
Yeah, so at this point, we're already seeing that the TSH is suppressed with still having a normal free T4 and a normal free T3. So this looks like a subclinical hyperthyroidism by that point already. At this point, the patient did not have symptoms. All right, so in repeating these labs, we wanted to confirm that there's resolution of that elevated free T4. And so at this point, it was deemed that there was no need for beta blocker therapy, but the team was ready to start levothyroxine if the hypothyroid phase resulted or became prolonged following this. So what happened next is the team went ahead and got a thyroid 123 iodine scan, and it showed 6-hour uptake of 0.6% and 24-hour uptake of 0.4%. These are both markedly reduced, and there was no hot nodule. And at the time that this was done, the free T4, or the TSH, excuse me, was already 0.4, which is at the lower end of normal. So it wasn't completely suppressed at the time this was done. A different provider had started methimazole, but then stopped after seeing the results of this scan. But the patient was not on methimazole at the time of the scan. The labs were continued to be followed, and you can see here that by May of 2021, that TSH has started to return. That's when the iodine scan took place, and that free T4 has actually come down quite significantly. And so this patient was diagnosed with subacute thyroiditis. And in terms of symptoms, I know we're looking at May already here. This patient's symptoms had already started to decrease by 2 weeks and basically had resolved by 1 month of therapy, or 1 month without therapy. And that corresponds with the improvement that we're seeing here in these labs. Oh, and even more labs for you. So you can see what happened to that TSH over time. So I wanted to pause here to talk about some clinical questions. So this patient had developed subacute thyroiditis 10 days after having her COVID vaccine. So I wanted to start by asking our group here, what is your experience with thyroid disease that is associated with vaccination? And this could be COVID vaccination or any other kind of vaccination. Dr. Hong, are you on the line? Would you like to comment?
Yeah, no, thank you so much. Thank you for inviting me. So I think that my experience has been that there have been very limited cases of thyroid disease, either autoimmune or from just other causes of it. What's interesting about this case is that she is a female of childbirth age, and it was from an mRNA, very frequently from either autoimmune disease or from, other causes of thyroid disease. Typically, it's the mRNA versus the viral vector vaccines. However, very frequently they are women that will have either types of causes of this disease. So I think this case is actually extremely interesting.
Thank you, Dr. Hong.
Thank you for that. So COVID is so new. We don't have that much data about it. Most of the information that we have is in previous reports and is retrospective studies. New prospective studies, but there's still a lot of data that we have. When I look back to see the most association with COVID, there was one review article that was published in March of this year, 2022. And they looked at all the case reports that have been published about thyroid disease with the COVID vaccine. And then those they were PubMed, Web of Science, and another search engine. So they found there were 83 cases. these 83 cases, 68% of those were associated with messenger RNA vaccine. 15% were associated with viral vector, so the AstraZeneca and the Johnson & Johnson might be listed. And then smaller amounts in the inactivated. Now, in regards to thyroid disease, the COVID vaccine, the most common one seen was subacute thyroiditis, 60% of the cases. And then Graves' disease was following second at 3%, and then the rest were a little bit less in percentage. And I agree, most of them were women, middle age around 40s, and the duration of onset, when it starts, is around 10 to 14 days after the vaccine. Now, the exact cause is still up for debate. There's a lot of data about it. There's various theories that have been faced. I don't want to take anyone's role in going over them, but I think the one that's most commonly thought is that the thyroid cells, they display the SARS-CoV-2 receptor, otherwise known as the angiotensin-converting enzyme. And the vaccine, the COVID vaccine, one of the protein 2, it actually binds to this receptor, and so it can lead to thyroid destruction, etc. There's also data that maybe it can act as an adjuvant itself, the COVID vaccine, the messenger RNA, even though it doesn't contain any antigen for the vaccine itself, but it can act as one because it is an immune. I think the rest need to be studied, but the data is interesting.
Thank you, Dr. Hage.
Can I please request the panelists to be a little bit louder? Our audience are saying the one who are virtual that they can't hear you.
Oh, sorry. Oh, there we go. It was working.
Thank you.
So, Michelle, I have a couple of questions.
So I wonder what the clinical trial data were. There's been several trials with the vaccines, and I wonder what the rates are, that are reported. And is there a correlation between the first shot and the second shot? Because the second shot, activates the T cells, and how does that play into the pathogenesis of all of this?
Those are wonderful questions. I will just say one thing from the case series that I have reviewed. It generally tended to be, ironically, the first shot that caused some of the issues, but maybe that was just purely anecdotal. Does anybody else have any thoughts on Dr. Kashup's questions?
That case review study actually looked at it because the first one and the second one. And there was that they did not, if anyone did not have any symptoms in the first one, they can develop the second one. So it's almost the same percentage.
So in that review, did they say that the patients that are this patient, for example, this patient, I think he had something brewing even before.
So I looked at that specifically. Only 2 patients had prior thyroid disease out of the 83 that they know that they know. But no one actually tested it before to compare it. So that's the recommendation.
And that kind of leads us to my next kind of overall question for our group here, which is what evidence would you want in order to be convinced of a causal relationship between vaccination and thyroiditis? I think we talked about a few things already. Right now, we don't have enough information. We just have some case series, case reports, and a review. But what would help convince you that this does or does not exist?
Dr. Hong, is there a definition in the immunology world that talks about vaccination and a post-vaccination effect? Is there like a time period that you guys use in the immunology world?
So from the autoimmune data, you would actually take a look at and see if there's anything like ESR elevation, CRP elevation, and for these like antibodies towards thyroglobulin or anti-TPO that would help you to actually think that whether or not something like this was due to something like Hage syndrome. Very frequently you would have symptoms from them. You would very frequently have myalgias and fevers and arthralgias when looking at it from that standpoint. From the standpoint of subacute thyroiditis, there really isn't anything specific that would help you define or Graves' disease. Typically, it'll be temporal relationship that'll give you the impression whether or not it would be. And in this case, there really weren't any other causative factors, anything that would have triggered her to have any type of thyroid dysfunction. So I think it's reasonable to consider that this one was due to the vaccine, especially with other reports in the literature out there, as Dr. Palenka had mentioned.
Thank you, Dr. Hong. For the sake of time, I'm going to start our third question here for our group, which is that what would you tell patients who are worried about thyroid disease with COVID vaccination? I'm sure we've all had patients ask us at some point or another, what do we generally tell them?
I think Dr. Hong maybe gets more questions than us about the vaccination. Any thoughts on how you counsel patients, especially for the COVID vaccine?
Yeah, so for the COVID vaccine, I think pretty much the way that we would counsel anyone that these are rare and infrequent side effects, and the actual benefits highly outweigh the negative effects. Specifically talking about thyroid disease, and particularly the study that Dr. Palenka had mentioned, very frequently all of them self-resolve, especially from a thyroid standpoint. They're all typically very mild, and they on their own, kind of in time, don't need much treatment, similar to our patient, where they actually just self-resolved on their own. From the standpoint of autoimmune, looking at things like like ITT or any of the other like myocarditis, again, very, very infrequent for any of those symptoms. And again, generally, as the FDA had kind of taken a look at all of these vaccines, just truly the positives outweigh the negatives in any way, shape, or form.
Thank you, Dr. Hong. Dr. Hage, you were seeing these patients probably before they were ready for the vaccine.
So this is very, very interesting. I always say, I mean, obviously I would recommend the vaccine. I would tell them to of course, take the vaccine, but I tell them that the data is new. We don't know. I don't even know what incidence specifically of those that do get the vaccine actually develop thyroid disease. There has been case reports, but I don't know what that percentage is compared to the billions of people that have actually gotten the vaccine. I tell them there's a potential risk that if they do have hyperthyroidism or underlying Graves' disease, it could be worsened after the vaccine. And I tell them about symptoms to watch out for. But most of my patients, after you counsel them, they're willing to go ahead and take.
All right, thank you. So I'm going to go ahead and present a little bit of my literature research here. So as has been mentioned here, there are multiple case reports of thyroiditis, both associated with the vaccination as well as even more associated with COVID infection itself. But I do want to avoid any potential overlap with Dr. Ladenson's talk here. So I've been asked to talk about a related concept, which Dr. Hong has alluded to here, which is this vaccine-associated autoimmune disease, ASIA, or autoimmune inflammatory syndrome induced by adjuvants. And so this was first described by Schoenfeld in 2011, and is unfortunately frequently cited by those who are against vaccination. But it posits that there are adjuvants that are being used to boost the immunogenicity of vaccines, which can itself induce autoantibodies or inflammation in the body. And so the most notable ones are the aluminum adjuvants, particularly aluminum phosphate or hydroxide. These are known to enhance antigen presentation, complement activation. The innate immune system stimulates with these, and the T helper cells are activated with these aluminum salts. But there are many examples, not just aluminum, and it's not just limited to vaccines either. So it's been linked with other exposures, such as silicone that is used in medical implants, which has been linked with arthralgias, headache, fatigue, and weakness that are not able to fulfill any other criteria for a known rheumatologic disease. Also, you might have heard of Gulf War syndrome. It is known that those who worked or are veterans of Gulf War, they developed fatigue, muscle aches, arthralgias. And it was thought to be related possibly to pyridostigmine, radiation, or the military vaccination schedule. So something I learned is that to be in the military at the time of the Gulf War, you needed to have 6 6 shots of anthrax vaccine, which contains both aluminum and squalene. And squalene has been associated with weakness and arthritis in mice. There's also something called the macrophagic myofasciitis syndrome, which posits that there are aluminum crystalline molecules that get in macrophages that get in between muscle fibers, and that can cause many of these nonspecific symptoms. And this has been related to the hepatitis A and B vaccines, as well as the tetanus toxoid. And then sick building syndrome is a little bit more vague, but it's the idea that there are nonspecific symptoms that are associated with residing in a particular building. So residents of this building, and the symptoms are often linked to the duration of time in which somebody is there, and they somewhat resolve when you get yourself away from that exposure. So it is thought that Asia is multifocal between environmental factors as well as genetic predisposition, because it has been linked more to people who have particular HLA genetic predispositions. And the mechanism is really unknown at this time. There's a question of molecular mimicry or formation of immune complexes. We don't really know. We don't have a lot of information about this. It's very controversial. So Asia syndrome is reported as early as 3 to 5 days after vaccination, and there are reports with hepatitis B, HPV, influenza, H1N1, and even with some things that aren't vaccines like interferon or IL-2 treatment. And the disease presentation can be very varied. It can be anything that we consider like an autoimmune condition like lupus or Sjogren's arthritis. But you'll see I have underlined here, thyroiditis is on this list as well. So there are multiple case reports of people who develop thyroiditis as part of this quote unquote Asia syndrome. And it's interesting because thyroiditis we know is one of the most common autoimmune conditions, or thyroid disease is, but yet it's actually one of the more rare autoimmune conditions associated with this Asia syndrome. And there are major and minor criteria that are used to diagnose Asia. However, they are very broad. There are over 4,000 cases that are reported in the literature of this Asia syndrome. They are very varied both in their supposed stimuli as well as in their disease presentation. And so there has been critical appraisal of this, and by a systematic review, they found that there was no reproducible evidence for any consistent relationship between adjuvants and autoimmune conditions. So possibly no reproducible evidence for this. And to go even further, there was a study of patients who were getting immunotherapy that they get high aluminum content as part of this immunotherapy that's on the order of 100 to 500 times the amount that you would get in a vaccine. But it was over the span of 3 to 5 years. And those patients who were exposed to this did not have increased autoimmune conditions. So this is another piece of evidence, perhaps against one of their biggest posits, which is that it's aluminum salts that are leading to this this condition. So overall, the evidence is weak, but our patients are able to read about this, and many of them might have come and have questions about Asia syndrome or not want to get vaccines because of Asia syndrome. So we should be aware that this exists and that this is still being investigated. Now you might be wondering, because after reading about Asia syndrome, I just wanted to know what is in a COVID vaccine. So this is from the CDC's website, the full list of ingredients for each of the main 3 ones that we use here. I'll do the quick glance over for you here, but there are no eggs, preservatives, or latex, and definitely no aluminum in these as well. However, some authors postulate that the PEG, the polyethylene glycol that you can see is in both Pfizer and Moderna, could be related to this Asia syndrome. So it's unclear at this point in time if this could possibly be related, though I will note that Johnson & Johnson has an equal number of related cases with it. So if it really is the PEG, then why would that one also have these autoimmune thyroiditis cases? But I just wish to acknowledge that there are many mechanisms by which thyroiditis could occur related to the vaccination, and we just had the opportunity to talk about one today, which was Asia, and that's by my skepticism of Asia, I certainly don't want to exclude that there could not be a different mechanism by which this exists. So to bring us back to summarize our case, and then I'll open things back up to our panel and our audience here. So we presented a case of a 36-year-old woman. She presented with palpitations, and her evaluation was consistent with subacute thyroiditis. And she had onset just 10 days after receiving her Johnson & Johnson SARS-CoV-2 vaccination. So we shared the controversial concept of autoimmune inflammatory syndrome induced by adjuvants, which is called ASIA. And it is unclear at this time if there's an association between the vaccine and subacute thyroiditis, and if so, by what mechanism this occurs. Because at this point in time, we just have case reports, case series, and some early review data that suggest this. But I think everybody here agrees that at this time, we would still encourage those who have thyroid concerns to get vaccinated, whether that's for COVID or for any other relevant vaccine. All right, and I'll open things back up for thoughts. I think I'll start with Dr. Hong here first. I know I just talked about something outside of my area of expertise here. Do you have any other thoughts on ASIA syndrome or anything to add to what I presented here?
Yeah, so the idea of autoimmune disease to any vaccines is actually really interesting to me. I had the same question as you did, Michelle, on what could the adjuvant have been. The fact that this patient had J&J as opposed to having one of the mRNAs. And one of the thoughts had been that the histidine or the buffer, like the buffer or the polysorbate 80 could actually be the cause of some of the autoimmune disease, just for the fact that they potentially play a role in anaphylaxis and other types of hypersensitivity reactions like immediate anaphylaxis. Similarly, the thoughts had been that, it's possibly the mimicry. The mRNA vaccines can cause a cascade of immunologic events that kind of just basically cause the immune system to flare up. It's interesting because there had been some thought that, as you'd mentioned, interferon, out in the literature of autoimmune disease, basically when we were treating the hepatitis or hep C, we were using interferon at that time, and very frequently there we're seeing increasing cases of lupus at that time. So what's interesting about these vaccines are that if you substitute the uridine with a pseudouridine in the mRNA vaccines, you actually show a decrease in, the interferon production, and the immunogenicity of it. So one of the thoughts are, if we're seeing increasing doses or increasing rates of autoimmune disease, not specifically ASIA, but any of the other autoimmune diseases, could you actually kind of make some changes in the vaccines to decrease this risk of autoimmunity of any sort? Again, tough to actually say if this was ASIA syndrome. Very frequently you'll actually have, all of these other like symptoms of, again, like fevers and myalgias and arthralgias and cognitive impairment and fatigue. And luckily in this patient, there was really minimal, if any, symptoms, minimum symptoms, but all self-resolved without requiring any sort of anti-inflammatory treatment. So not entirely sure about ASIA in this particular case, but I really think it's really important for people to be aware of it because, again, like people that kind of tout anti-vaccination, this really can come up as one of the reasons why they would not want to get it.
Thank you.
Dr. Hage, any last comments or thoughts?
Thank you very much. We did work in this, so there's a lot of case reports out there. The date hasn't really been 100% established. There have been association with some vaccines, or possibly because some vaccines with autoimmune diseases. I've seen a few cases. I don't know the relation. It could be just a coincidence. There could be something there. I think it's interesting, and our clothes prove it. Otherwise, it could be consideration.
Thank you.
Thank you so much, Dr. Lundholm. As Dr. Hong pointed out, I think it's important for us as clinicians to know about the actual data behind some of these things because our patients are going to ask us. All right, so now it's time for our next speaker.